Chiński, and this is Ewelina Cieplińska. We are the members of the Surgical Scientific Student Group of the 3rd Surgical Clinic in Kraków. I would like to present a case of habitual intentional foreign body ingestion we have prepared together under the supervision of Dr. Alexander Konturek. Foreign body ingestions fall into two categories: accidental and voluntary. Accidental ingestions are more common among children, elders, alcoholics, and drug addicts. The most common ingested objects include food foreign bodies and dentures. Voluntary foreign body ingestion has been reported most often in prisoners, suicidal patients, fakirs, drug dealers, and psychiatric patients. This CT scan and 3D reconstruction showed the location of the two metal spoon handles swallowed by our patient in 2009. The first one is located in the stomach, and the second one can be seen in the cecum. The swallowed foreign bodies can usually be found in narrow anatomical, physiological, or pathological locations. Typically, those locations are the cricopharyngeal ring, the lower esophageal sphincter, the pylorus, the duodenal sweep, the ileocecal valve, and the anus. How big is the risk of operation when a regular person accidentally swallows a foreign body? 80 to 90% will simply pass through. 10 to 20 require endoscopic removal, and the surgical operation is needed only in 1% of cases. However, intentional foreign body ingestions carry much higher risks of complications and therefore require surgical interventions in up to 76% of cases. Typically, the patient will get a preoperative diagnosis of an acute abdomen of unknown origin. The location of the FB affects the presentation and severity of symptoms. FBs located in the stomach, duodenum, and large intestine tend to give milder and more chronic symptoms. On the other hand, symptoms of FBs in the small intestine are more pronounced and severe. Let's meet our patient. The patient is a 62-year-old female. She is a welfare house resident and is mentally and cognitively handicapped. She suffers from epilepsy, discoid lupus, and hypothyroidism. The patient has had numerous operations caused by foreign body ingestions. Some of them had complications, which resulted in a right-sided hemicolectomy. In short, in the span of 17 months, the patient had 5 laparotomies, which resulted in the removal of a rather astonishing number of 32 foreign bodies. On the day of the last admission, the patient was conscious but disoriented. Her welfare institution caretakers reported that 4 days prior the patient had a subfebrile temperature, lack of appetite, and appeared fatigued. On the next day she vomited. On the day of admission she had significant abdominal distension. The patient's lab results and clinical symptoms pointed to an inflammatory process in the course of peritonitis. Due to the patient's history, the ingestion of a foreign body was initially suspected to be the cause. But would imaging confirm this suspicion? The abdominal X-ray and ultrasound showed no trace of a foreign body. Considering the patient's history, this was a bit of surprise. The next most probable diagnosis was an intestinal blockage caused by adhesions formed after multiple operations or by a malfunction of one of the stomas. There is no universal treatment for a foreign body ingestion. The goal is to make it effective but as non-invasive as possible. If the object is located in the stomach or duodenum, it should be immediately removed endoscopically. If the object passes through the duodenum, the patient should be monitored daily through X-rays and remain under close observation. Surgery is necessary if the object has not progressed after 72 hours. The emergency laparotomy is required if the patient develops clinical signs of acute peritonitis. And this, the acute peritonitis, is what happened. On the 3rd day after admission, the patient was qualified for surgery with a preoperative diagnosis of an intestinal blockage of unknown cause. Adhesions were removed. The small and large intestines were dilated to the sigmoid level. The first foreign body, a plastic spoon handle, was found in the midsection of the small intestine. It had perforated the intestine wall and caused phlegmon of the mesentery. The second FB, two plastic spoon handles, went through the sigmoid mesentery and became lodged between the wing of ileum and the iliopsoas muscle, which caused the intestinal blockage. The intraloop abscesses were drained. The total of 3 foreign bodies, plastic spoon handles, were removed. A terminal ileostomy and a left hemicolectomy were performed with resection of the ileocecostomy. The patient was qualified for a second look procedure. She was reoperated and had 3 more laparotomies. Luckily, the patient was discharged in good condition after treatment in the ICU. As this case illustrates, reaching a final diagnosis can be really problematic. The interview plays a crucial part and narrows the task to locating the foreign body in the gastrointestinal tract. However, particularly very young, old, and mentally handicapped patients may not be of help with this step. The symptoms do not differ from other acute abdomen causes, such as diverticulitis or appendicitis. Lab results may help to assess the severity of ongoing process and to determine if the surgeon should operate. Plastic foreign bodies are radiolucent or routine radiographs. Conclusions. Plain radiography is unreliable in perforations caused by non-metallic foreign bodies. Abdominal CT is the recommended diagnostic procedure. Physical examination plays a crucial role in diagnosing an acute abdomen, regardless of its cause. In this case, the definite diagnosis was reached through surgery. Take-home message: watch and see. Constant physical evaluation of the patient's symptoms helps make the right treatment decision. Best results can be reached through close cooperation of a team, including a surgeon, radiologist, psychiatrist, and nursing staff or caretakers. Thank you for your attention.